Hello, good evening, everyone. Welcome to our next chapter today. Today we'll be studying thyroid and parathyroid gland pathology. We have already completed physiology. It's time for pathology. Okay, I'm sorry, we have not completed the physiology of parathyroid hormone. First, we will go with physiology of parathyroid hormone, and then we will go with pathology of thyroid hormone. I hope you have already studied from your part also, and you have your notes and FA ready. I hope I am audible and visible. Please comment. Am I visible? Is my screen sharing? I hope you guys had a very wonderful Holi, and for me also it was a very memorable Holi, as because along with Holi I have admitted with Gynae. I have completed the admission of Gynae today, so it has been a very good time for me as well. So let's begin. We'll go with parathyroid hormone. And as we know, it's the hormone released by parathyroid gland, chief cells of parathyroid gland. And the main function, just remember just two things. Parathyroid is phosphate tracing hormone. That means it will remove phosphate, first thing. And the other primary function is calcium reabsorption or increase free calcium in the blood. If we remember just these two things, then we can go with any regulation or anywhere we can study this thing. पहिलो कुरा चाहिँ increase free calcium in the blood, and second thing is decrease phosphate or phosphate tracing hormone. So how it will increase calcium in blood? It will increase absorption, resorption, and reabsorption. Absorption from GI, whatever food we intake, it contains some amount of calcium, and so absorption from calcium and absorption from intestine, and then also it goes to blood, then it goes to cells, then it goes to liver, then it goes to kidney, and in the kidney, major function is excretion and reabsorption. So whenever to maintain homeostasis, there will be increased calcium reabsorption, and that is maintained by parathyroid hormone. And again, reabsorption from both from distal convoluted tubule. We can see this in renal system also. We'll see this. And other thing is bone resorption. So whenever both the mechanisms fail to maintain the homeostasis of calcium, then the major source of calcium is within the bones, and osteoclasts will get activated, and then calcium will be released. So overall status is to maintain free calcium, mind this term, free calcium in the blood, and it will also increase the active form, trial production by activating. You don't need this enzyme. What we need is what the question that is asked is what is the active form of vitamin D? Active form vitamin D is calcitriol, or when there is no calcitriol, 125 dihydroxy cholecalciferol. Okay, so here it is. PTH increases serum calcium, decreases serum phosphate, how it will decrease serum phosphate is it will increase urine phosphate excretion. And this is a bit complicated thing. We will study this in uh, musculoskeletal. It is about osteoclast. Osteoclast get activated by rank receptor, which is activated by osteoblast. This is what the basic thing is here. And other thing is parathyroid related peptide functions like pyrethormone, which is increased in case of malignancy, commercial carcinoma, lung, renal carcinoma. This is also important. So regulation is the same thing when calcium decreases, PTH increases because the function of parathormone is to increase serum calcium. And when in for phosphate increases, parathormone secretion also increases. In this way, there is a mechanism of regulation. We need to memorize this picture. This is the pictographic memory. If you understand this, if you have this memory, then you can attempt any question. So first, how parathormone will get activated or how it is released. We have four parathyroid glands, superior parathyroid gland and inferior parathyroid gland. Though it is not given here, but there has been asked the questions about the development of parathyroid gland. Not directly, but they will ask you, uh, yes, directly. They will ask you like where is superior parathyroid gland formed from, and there will be options superior and inferior. So how we can remember is like though inferior, but it will be from third pharyngeal pouch, and in superior will be from fourth. Memorize this thing, and also when it is released, then it is released in circulation, and it will act on renal tubular cells, and it will help active form of secretion, which has the major function of reabsorption from the PCT. And also, this will there is a concurrent vitamin D role going on. So it's in the form of 25 hydroxy cholecalciferol. Then one you don't need this enzyme, and then the active form is formed, which will act on bone. And also, it has been asked like where it is formed in skin, in liver, in kidney. The mechanism of activation of vitamin D is also necessary, and after it gets activated, activated in kidney. After it gets activated, then it will act on bone and here and intestine and bone. We know resorption and intestine absorption, and ultimately the major activity is increased calcium and increased phosphate. Here it is increased calcium and decreased phosphate. The difference in parathormone and vitamin D, though they both activate 125 hydroxy cholecalciferol, but they have a slight variation of secretion or slight variation of function related to parathyroid. Okay, so in our body there is ions of three form of calcium bound to albumin and bound to anion. This is what is functioning. Mostly 45% is active form, and ionized or calcium. It is the primary regulator of parathormone. We have seen all before also. So change in hormone concentration do not regulate it. And also we can remember that increased pH will decrease ionization, and the symptoms of hypocalcemia are ataxia symptoms, and when it is severe it goes to carbopedo spasm, and when it is less, that is alkaline environment, then there will be decrease in CTS. Just remember that we should remember only one side, that is in acidic condition there will be decreased ionized calcium, and those features of hypocalcemia. And ionized calcium is what is active and what does all the mechanism. And similarly, the calcitonin is counter-regulatory hormone of parathormone, that is do all opposite function to parathormone, and it is secreted from C cells of thyroid. It will resorption, it will increase serum calcium, and here it opposes the action of PTS. So we don't need to remember much, only we'll remember that it acts just opposite to parathormone. Glucagon, as we have said, it will be secreted in response to hypoglycemia, and it will do anything to increase blood glucose when it is too low, and we also use it in conditions of refractory hypoglycemia as treatment, as we have seen before. So once we have completed the physiology of parathormone, I hope it is easy. Now we'll go with pathology of parathormone. And this year in 2080, we had a question: parathyroid hormone, or let's say calcium homeostasis. It is slightly confusing, but I'll state the question over there. We'll figure out. This is all about thyroid. We'll go over there. So they have given a very beautiful chart, a beautiful spectrum for diagnosing parathyroid disease. When we go to this chart, let's go to know about this parathyroid, hyperparathyroidism. Okay, there are three types of hyperparathyroidism. So we have four also. Hyper means increase in anything, so increase in parathormone. And there is, when there is primary term, that means there is a pathology in the organ or gland itself. When it is primary hyperparathyroidism, it is due to parathyroid adenoma or hyperplasia. That means it will be acting more and more. And when it is acting more and more, that means it will be releasing more and more hypercalcium. Means it will increase calcium level, and then it will go to urine, causing renal stones, and polyuria, causing stones. Also, hypophosphatemia. I hope it becomes much clearer now when we know the physiology, when we know the basic mechanism of parathormone. We can say the symptoms of hyperparathyroidism. So there is a term, okay, and here it is: increased PTS, increased ALP, and you don't need this. So bone pain, that is groans, abdominal pain, flank pain, kidney stones, neuropsychiatric disturbance, psychiatric overtones. So this is the mnemonic of hypercalcemia or hyperthyroidism: stone thrown, bones, groans, and psychiatric overtones. If you remember this, that means in kidney stones, stones is also the same thing. In the bone, there will be bone pain, abdominal pain, groans, and neuropsychiatric disturbance, also known as psychiatric overtones. We don't need this, but if we are studying for India exam, then you need this picture, which shows that there are these cystic bone spaces, osteoarthritis fibrosa cysta. That means there are cystic bone spaces. Is due to brown fibrous tumor, also known as brown tumor, and it has osteoclast and deposited hemocysteine from hemorrhage, and this is usually primary or secondary hyperparathyroidism. Now, talk about secondary hyperparathyroidism. So secondary hyperparathyroidism, the main difference is there is hypocalcemia. Okay, due to many reasons, there has been decrease in calcium level in blood. Okay, and so body will try to do what? Body will try to increase calcium level, and to do so, it causes secondary hyperplasia in parathyroid gland as because there has been absorption or increase in phosphate. And especially the main cause is CKD. Just remember secondary hyperparathyroidism due to CKD. Kidney is not absorbing calcium properly, and due to this, we are not able to reabsorb it properly. Body is insufficient in calcium, and then there will be secondary hyperplasia and also hyperphosphatemia. This is all we know to know. And due to this, if there is bone lesions, okay, a renal disease, the term is here renal osteodystrophy. If any renal disease is causing lesion, then it is known as renal osteodystrophy. And as it goes on, as the hyperplasia continues, the CKD hyperplasia continues, and what happens is there will be a refractory or autonomous hyperparathyroidism, and this will cause very high level of PTH and high level of calcium. You don't need this one. So we'll go with this chart. This hypercalcemic chart. This is only hypercalcemic chart. Okay, there is no hypercalcemic chart, but you can just make one. So there, the major difference is in primary hyperparathyroidism, there is hypercalcemia. So all the features of hypercalcemia and hypercalciuria, hypophosphatemia, whereas secondary it's hypocalcemia and hyperphosphatemia, and in tertiary also it's very high level of parathormone and hypercalcemia. And there is also hypoparathyroidism. This happens when the most common cause is iatrogenic. Okay, this is also a question because while operating thyroid glands during thyroid surgery, as thyroid and parathyroid are very closely related, there might be damage to parathyroid glands or their blood supply or due to autoimmune destruction, Tiger syndrome. So what it will do is because the parathyroid glands is the hormone which is acting to increase serum calcium. Due to its deficiency, there will be tetany, hypocalcemia, hyperphosphatemia. And these two signs are very important. We have got questions over these signs also. Chopstick sign, just remember CH for CH, cheek, tapping the cheek. When we tap the cheek over the facial nerve, there will be contraction of facial muscles. You can go on and watch the videos. There is a very good videos of this sign, and once you watch the sign, you can clearly remember that. And also the Trossier sign, which is when we cough. Remember for TR, when we cough the baby cough, then there will be occlusion of brachial artery, which is called carpal spasm. So these two questions are important. And this pseudo hyperparathyroidism part is not important for CE exam. If you can study, you can go with it. And so also like there will be many different conditions causing hypocalcemia. Okay, even we saw that secondary hyperparathyroidism. Even when there is hyperparathyroidism due to CKD, also there is hypocalcemia. So what are the conditions? As we can see from okay, it's gone over. We have already seen that vitamin D has also major role in maintaining the homeostasis of calcium. So here, when there is vitamin D deficiency, calcium deficiency occurs, and when there is hypoparathyroidism, obviously this pseudo hypoparathyroidism is a condition in which there is a resistance to parathormone. It's not that parathormone less, but the bones, the kidney, these are resistant to parathormone. This is pseudo, and also due to hyperphosphatemia. As we have seen, there is a regulatory mechanism of higher phosphate in calcitonin and parathormone. So this is a thing, but we have to remember the mainly you can see that with calcium decrease everywhere there is increase of phosphate except, so just remember this except in vitamin D deficiency. As we have seen, in vitamin D deficiency there will be increase in decrease in phosphate. Okay, and also we can see that in every aspect, when calcium is decreasing, parathormone is increasing except hypoparathyroidism, because the primary pathology is within the parathyroid gland, so it cannot get enough of parathyroid gland. Otherwise, when calcium is decreasing, phosphate is increasing except vitamin D deficiency, parathormone is increasing except hypoparathyroidism. ALP is increasing everywhere and vitamin D is decreasing everywhere. So this chart is made simple. Now we'll go with the question that was asked in 2018. They had given us values of all these parameters. So they had given like the calcium level is this much. Just a minute. I have a question. So for that, what had to be done was we had to remember the normal level of all these. So calcium level was given, phosphate level was given, and ALP level was given, which was very high. That was 960. As we have seen that ALP level is also increased during bone disease and liver disease. We had seen in GIT also that how can we difference whether it is due to the LP raise is due to liver pathology or it is due to bone pathology, and there it comes gamma GGT comes in role if it is due to alcohol, and if it is due to uh, problem with liver, then gamma GGT will increase, whereas if it is due to problem with bone, then only ALP will be increasing, gamma GG will have no role within that. So in this question, the calcium level is within normal range, phosphate level is within normal range, and ALP is very high, and there were options like hyperparathyroidism, there were options with multiple myeloma, and also there was option with old age or process C. I had ticked with multiple myeloma because calcium is also normal, phosphate is also normal. If there was any pathology with in the parathyroid gland, as we can see, there will be either calcium decrease or calcium increase or phosphate increase or phosphate decrease. And there was nothing about parathormone. There was only thing about ALP hormone. So you can just try and find the answer of this question. So this was the question that was asked, and maybe we need to learn this, these things and normal mechanism. And here it is a approach to diagnosis. So calcium somewhere it was given between like 6.5 or 8.5, 8.5, and as we can see this for this chart we need calcium parathormone level Parathyroid level to 10 to 15 is normal, and for calcium 8 to 12 or 8 to 11.5 is normal. And when we see that calcium is decreased, okay, and what we had said, whenever there is calcium decrease, parathormone should rise, because the role of parathormone is to increase our calcium level. But calcium is not, sorry, parathormone is not increasing, rather it is decreasing. It means there is some pathology with hyperparathyroidism. The parathyroid gland cannot secrete enough of parathormone. It may be due to autoimmune destruction, it may be due to surgical dissection. This is called. The other part, when calcium is low but parathormone is very high. Okay, so this is where we have seen in chronic kidney disease, that is due to vitamin D deficiency and decrease in calcium intake. So this is due to secondary hyperparathyroidism. Secondary hyper in two hyperparathyroidism, primary and tertiary calcium level was high, but in secondary hyperparathyroidism, calcium is high. Calcium is the parathormone is high, but still calcium is low. And this is normal. Okay, calcium is also, and parathormone is also high. And here in this PTH, independent hypercalcemia, so parathormone is high, but still calcium is not, sorry, calcium is high, but parathormone is not that high. And this is because it is not dependent in PTS. It is like we have seen that in with increasing vitamin D, with paraneoplastic syndrome. It's not only parathyroid gland, but other parts are also secreting parathormone like peptide, which is playing role with this calcium metabolism. So first, okay, we'll know about the calcium level. We'll look after phosphate level. We'll hormone, and we'll look after ALP. So me telling it once may not help you in memorizing it, but if you solve the problems related to it, and you can go with any app, you can go to the endocrinology, you can go to parathyroid, and if you try in PPG app also, there are a lot of problems related to this, and if you stimulate your mind in learning this, then obviously you will remember this thing. Just remember this basic theories. Okay, so we have completed a very complex pathology of thyroid. Mm, I hope I could make it simple. Now we'll go with thyroid hormone, and this is one of emerging conditions. Uh, Maybe due to screening tests, maybe due to rapid availability of tests, or maybe due to some defects in our food and feeding habits. We have been seeing lot of thyroid cases recently, thyroid cases of thyroid imbalance. Mm, we have learned the physiology in previous class. Today we'll just go with the pathology of thyroid gland. And I had said to make a chart before also, so where we will write the hormones, and then we'll write what happens when it increases and what happens when it decreases. We'll just go and make the chart, like with increase in hyperthyroidism hormone, it is called hyperthyroidism, and with decrease in thyroid hormone, it is called hypothyroidism. It seems to be very basic, but sometimes in rush we do not look at the term, and then it will make a problem. So ATP generation is there, that is keeping our body warm, feeling okay, and there will be no sweating. Okay, and since BMR is also less, ATP is also less, the weight gain. Okay, here it is, basal metabolic rate and decreased calories. And also remember hyponatremia. So they will dry, cool skin due to decreased blood flow. So coarse, brittle hair, decreased alopecia, brittle nails, puffy face. generalized non-pitting edema, mixed edema. Okay, there are two types of edema that you need to remember. We often get to confuse with mixed edema and pre-tibial mixed edema. Okay, so when there is a patient with such kind of lower limb non-pitting edema, okay, and at any location, this is in scene of tibia. This is myxedema. It's usually generalized with moon face, puffy face, and why it occurs is in the interstitial space, like between cells, there is a space, and here there will be collection of gas, that is glycosaminoglycans, and this will increase osmotic pressure and cause water retention. So this is the basic physiology, increasing gas. And then ocular periorbital edema, okay, constipation, decreased appetite, hypothyroid, myopathy. This is also important. We see with many patients who have hypothyroidism, they are telling that they are not able to comb their hair properly, they are not being able to rise from sitting position. This is all due to proximal muscle weakness, and this is important. Carpal tunnel syndrome, as we have seen that there will be collection of gas, there will be also collection in carpal tunnel, and this will cause compression of median nerve, and then there will be a myxedema, myodema, that is muscle also will have some lump, okay, and abnormal uterine bleeding, decreased libido, infertility. Okay, reproductive, both in both same, abnormal uterine bleeding, decreased libido, infertility, gynecomastia. So with any case, even these days with fertile cases also, with cases that comes for antenatal checkup, thyroid hormone, at least PSA screening is being done, and with those cases which who come with infertility, thyroid test is must. Neuropsychiatric condition, we can see hyperactivity. Okay, the patient is hyperactive, lethargy, fatigue, weak, depressed. Depressing is very important, and also decreased reflex or delayed cerebral activity. Bradycardia, dystonia exhaustion. So you can see that everything is delayed in hypothyroidism. Your body is cold, skin is dry, alopecia, menstrual problem, decreased GI motility, that is constipation, decreased appetite, uterine bleeding, abnormal infertility, decreased activity, fatigue, weakness, everything is decreased. Whereas in hyperthyroidism, everything is increased. Heat intolerance, because body is already generating a lot of heat, there will be heat intolerance. Also, there will be increased weighting, weight loss. Okay, same theory. Then warm, moist skin, fine hair, onycholysis, that is detachment of nail. We can see here this part, and we can see ophthalmopathy in grapes, the peritable myxedema, that is in front of tibia only, there will be swelling. Ophthalmopathy in Graves' disease, orbital edema, exophthalmos, lead lag, lead distraction, and hyperdefecation, diarrhea, increased appetite. Here also they will have myopathy, okay, and osteoporosis fracture. This is very important. It is directly proportional to thyroid hormone. So those persons with decreased thyroid have more tendency of fractures, osteoporosis, hyperactivity, restlessness, anxiety, insomnia. Everything is increasing with the anxiety effect, and also increased reflex. Okay, somewhere this is also in the clue or question for hypothyroidism. And in this 2080, they had given a case, features of tachycardia, palpitation, pregnant female. So they have incorporated like gynae, pharma, and you need to diagnose that this is the case of hypothyroidism first, and then you need to know which drug is given in hyperparathyroidism in pregnant in first trimester. Okay. So the answer is PTU, para. We have also seen before also propyl thyroid acid. This pain systolic hypertension, increased number and sensitivity. This is the same thing. So what we'll do? We'll do TSS. We'll do free T3 T4. Okay. Never forget it's F T3 F T4. As we have seen in physiology, the F3 is active form, and also this is also we had seen in seen somewhere that whenever a patient is hyperthyroidism, he will ultimately develop hypercholesteremia. And if primary decrease TSS increase, this is all due to feedback mechanism. Okay. Normally we are screening with TSS, and if TSS comes abnormal, then we'll do free T3 and free T4, and we'll do the treatment accordingly. So now we need to know about different causes of hypothyroidism. Number one is Hashimoto thyroiditis. Okay, so whenever it is thyroiditis, that is inflammation of thyroid gland. So there will be some pathology, and it is more oftenly leading to hypothyroidism. If it is any plasia uh, or adenoma, then we can think of hyper. So this is a basic, easy way to learn about any hyper or hypo cases. In this case also, so we'll see that with any thyroiditis, let's forget about the name. It's thyroiditis, it's thyroiditis, it's thyroiditis. Okay. So a Hashimoto is from the Japanese name, and it is chronic autoimmune thyroiditis. If you can know this only, then you know all pathology and physiology. And it is most common cause of hypothyroidism in iron sufficient region. Okay, if it is in iron deficient region, then hypothyroidism is that. But there is already enough supplementation of iron, but still patient is developing thyroiditis, or he or she is developing hypothyroidism, means there is Hashimoto thyroiditis. So there will be but non-tender thyroid. Why? Because it's chronic. It has already become chronic. So, and there will be also a transient hyperthyroid state in which there will be follicular rupture and thyroid hormone release. And serology is, this is what is important, anti-thyroid peroxidase. We have seen that PPO is the basic enzyme that is necessary for uh, organification, coupling reaction. And so when there will be antibody to this enzyme or anti-thyroglobulin antibodies which was binding with MIT-DIT, due to these two things, Hashimoto thyroiditis is occurring, and this is very, very, very important. H, remember H for H, Hurther cells. This has been asked many times. You'll see the picture. Though histology is not important, but just ask like Hurther cell is seen in or diagnostic feature of in this way. So this is Hurther cell, and if you are planning to teach in India or US only, then this picture is very, very important. And also there will be lymphoid aggregates with germinal centers. And so we'll remember like that there in our body antibody has been created against PPO, which will come and act on cells, that is follicular cells of thyroid gland, and they will destroy. So there will be a state of transient hyperthyroidism or thyrotoxicosis, because here the storage was of T3 and T4, and then it starts fibrosing, obvious chronic condition, and these follicular cells starts becoming non, but it is painless, and with long time it comes, it may go to primary thyroid lymphoma. And the pathognomic or diagnostic structure is Hurter. And also there will be a mild self-limited thyroiditis 1 year after delivery. मतलब after 1 year of delivery, a pregnant female may develop thyroiditis that is known as postpartum thyroiditis. And also subacute granulomatous thyroiditis. This also has everything in its name, okay, and also known as Burkian thyroiditis. It is a self-limited disease, okay, and there will be a transient hyperthyroidism, okay, then euthyroid normal, then hypothyroid, then euthyroid, and it is important there is a viral infection and also very tender thyroid. This is what we know to know in the difference. This is like subacute infection, and in histology there will be granulomatous inflammation. In riddle thyroiditis, it's invasive fibroid thyroiditis. It has IgG4, it's autoimmune, whatever it is. And then there might be hypothyroidism, which will be very extending, and it may go to like anaplastic carcinoma. And this is important. Hard rock-like fixed non-tender thyroid. We might get confused with carcinoma. So that's it. It is replaces fibrous tissue and inflammatory liquid. Hashimoto, Hershey's, subacute, there will be granuloma. In riddles, it will be hard, thick, rock-like structure. It may attach with esophagus. It is invasive fibrous. Just remember, like riddle is invasive fibrous tough structure that is also autoimmune and that is also causing hypothyroidism. And very important is congenital hypothyroidism. Hypothyroidism, also known as cretinism, and it is due to thyroid dysgenesis. That is, thyroid gland is not developed normally, maybe agenesis, hypoplasia, ectopy, or hormonal problems with mutation of thyroid peroxidase. So this will come in case scenario, especially when you see poor brain development or mentally retard, okay, a small child with mental retard and protruding umbilicus, protruding tongue, okay, pot belly. These mainly protruding umbilicus. Umbilicus is very big. Tongue is being tongue is coming outside, and patient is mentally retarded. Then we need to go with congenital hypothyroidism. That is, patient is deficient in iodine or patient is deficient in any hormonal stage from very birth. And the most common when we are like we are getting confused, what is the most common cause of hypothyroidism? We go with complex topics, but this identity and this has been also asked. It is most common cause worldwide, sleep, and it presents with goiter. What is the most common cause of goiter? Iron deficiency. What is most common cause of hypothyroidism? Iron deficiency. Okay. Okay. So here it is the protruded tongue, enlarged thyroid gland. These are the core spacious structures. You can see the hair, everything. And other conditions that will present with hyperthyroidism, that is excess of 3, T3 and T4 are most common cause. This question has been asked many times. Most common cause of hyperthyroidism is Graves' disease, and it is also anti-autoimmune due to thyroid stimulating immunoglobulin. Okay, and it will stimulate TSS receptor, normal fibroblast or vital fibroblast. So these T cells will cause, and also there is a secretion of gas, increase osmotic swelling, water inflammation, and exothermic. So what will happen is uh, antibody is developed, okay, And this antibody is what it is doing is this is stimulating TSH receptor. In other cases, usually antibody is decreasing the function, but in case of Graves disease, it is stimulating TSH receptor on thyroid gland. So it will secrete more and more of T3, T4, and it will also cause secretion also on fibroblast under skin. Okay, so it will cause peritoneal myxedema around eye. It will cause protrusion of eye and also activation of T cells. And this is everything is causing exophthalmos. That is, we can see normally this level of eye, ball, and lid, everything is at this level, but this is exophthalmos. And also it presents during stress, pregnancy condition, and HLA DR3. This, if you want to remember HLA, you can make a separate section or separate page for HLA, and then just write down all the HLAs that come during your study, and then you can revise later on. And the other cause of hyperthyroidism is toxic. Whenever the term toxic comes, that means there is increased secretion. Multinodular, there will be multiple nodules, and goiter is enlargement of thyroid gland. So there will be focal patches of hyperfunctioning cells with colloid, and they will be independent of TSS. Okay, and they will before, and they are rarely malignant. That's all. And thyroid storm is serious complications from means however means a very high release of anything. Okay, normally air is present around us, but when it becomes clear, then it is storm. Similarly, T3 T4 is there, but when there will be sudden that is there is a lot of T3 T4 due to stress, infection, trauma, surgery. Okay, the patient may come with agitation, delirium, fever, diarrhea, coma, tachyarrhythmia, and may cause death. Also, infusion LFT and treat with 4P, beta blocker propranolol, propylthiouracil, prednisolone, and potassium or Lugol iodine. Because iodide load will cause decrease in T4 synthesis. So, as I said, there was a question why? Because iodine is given before surgery, and there were two options. This was also there, and also there was decreased vascularity. I leave it up to you to find out the right answer. So this is also another mechanism. Not we don't need the mechanism, but we can learn that iodine-induced hyperthyroidism may also occur. And the cause of goiter, okay, we come to a patient comes to us, we palpate the thyroid gland, we find that there is a smooth diffuse enlargement, or we can find that there is nodular enlargement. If it is smooth, then we will go with Graves, Hashimoto, iron deficiency, or any tumor. And if it is nodular, toxic, multinodular goiter, thyroid adenoma, thyroid cancer, thyroid cyst. So when it is smooth, we don't need to be much worried about, because in most of the cases, not that much of a problem. But if it is nodular, then we need to find out the cause. And also, this time there was another question like you do FNAC, and you will find out it's a tumor which is not the tumor. So mainly, whenever we get the thyroid nodule, the, the common pattern is we start with FNAC, and then if FNAC is inconclusive, then we go with biopsy. Let's go with benign condition, adenoma. It is benign solitary growth, only single, unfunctional. So whenever it is cold and hot is based, cold or hot is based on uptake of iodide. Okay, if there is more and more uptake of iodide, then it is known as hot, and if there is less uptake, that means the functioning follicles are not functioning properly, and that means it's cold. And it may cause rarely hyperthyroidism. Okay, it's not necessary. Then usually there will be follicular growth and no invasion. Okay, so adenoma is simple benign condition, but follicular carcinoma is malignant condition. It will invade the thyroid capsule and vasculature. There will be uniform follicles. There will be hematologic spread, and this is the question that was asked. And this is asked, I think, 2 or 3 times before also that, and also it's represented as Thigh 3. That is, fine needle aspiration cytology may not be able to distinguish between follicular adenoma and carcinoma. Usually the histology is same. The invasion of capsule, whether there is invasion of capsule or not, is the major determining factor for diagnosing follicular carcinoma or follicular adenoma. And since in FNAC we don't know that, this is causing confusion, and we are not able to diagnose it. And this concept was asked in a uh, in a different pattern in 2080, a bit twisted pattern. Okay, and now we'll go with thyroid cancer. Okay, thyroid cancer is detected with fine needle. It is detected with fine needle aspiration. The cytology is there will be cytological changes that can be seen in FNAC also, and also there will be physical features of hypocalcemia, thyroidectomy, and it should be treated with thyroidectomy. And when there will be surgery, as we had seen already, there might be accidental removal of parathyroid gland or transaction of recurrent laryngeal nerve. Okay, this is asked in some mock question, like when we do thyroid surgery, which nerve might get in affected, and for left side, it's left recurrent laryngeal nerve. This will cause dysphagia, dysphonia, as we know that recurrent laryngeal nerve is responsible for nerve supply of all of our laryngeal muscles. And when we are doing superior laryngeal nerve, superior thyroid artery, it's like this. This is our sorry, this is our thyroid. Okay, with us. This is our superior parathyroid, inferior parathyroid, and this is the superior thyroid artery. This is inferior thyroid artery, and we with superior thyroid artery there is also laryngeal nerve SLN, and here it is recurrent laryngeal nerve. So when we are going to ligate this inferior thyroid artery, then it might cause injury to superior sorry in inferior thyroid artery it will cause injury to recurrent laryngeal nerve, and in superior thyroid in superior thyroid artery it will cause injury to superior laryngeal nerve. This is because they are in very close proximity. And also papillary carcinoma is very very important because this is the most common. Which is the most common thyroid carcinoma is papillary carcinoma. This is very important. Orphan and nucleus. See, they have a cell with no nuclei in center, and samoma bodies, nuclear groups. These three drums are important, and it has good prognosis. So whenever there is samoma body, when orphan and nucleus, it is papillary carcinoma of thyroid. And also they will ask you associated with men, which CI is associated with men. We know is medullary carcinoma, follicular, C is calcitonin, and this is not important. So okay, we have completed pathology section from everything. Just a bit of SAIDH is remaining. SAIDH and diabetes mellitus and this hypothyroidism. Let's say the pathology of pituitary gland is remaining. I will complete it in 5 more minutes. It has come before also the syndrome of inappropriate antidiuretic hormone. As we see, antidiuretic hormone will cause excessive water retention, and there will be so water retention will cause hyponatremia, and there will decrease aldosterone. So we don't need that much. Just let's remember that whenever there is excessive of SADS, especially you see this in old patient. Old patient comes with hyponatremia. We'll try to find out the cause, but we'll go with fluid restriction, and if not, controlled salt tablets, and we have a IV hypertonic saline, and this is the treatment of choice. We have said before also, DOCH, demiocycline, and the causes are like head trauma, ectopic ADS secretion, exonic hormones, lung disease, drugs. This is not that important. Just we'll go with the drugs, and if we can remember, just remember this osmolality values also. Other thing is diabetes insipidus. Diabetes insipidus. Diabetes means in urine. Insipidus is taste urine. There was diabetes mellitus, that is urine, but taste. Matlab, mellitus is sweet urine. Here is tasteless urine, that is production of large amount of dilute urine. And we can see we had already said that central DI is due to hypothalamic, and the nephrogenic DI is due to ADS resistance. That's all. And primary polydipsia is due to psychiatric illness. The patient may take a lot of water. And how we'll differentiate it is with water restriction. If it is primary polydipsia and patient is not taking it water, that means it will increase urine osmolality. But in diabetes insipidus, there will be no change. And we'll differentiate central diabetes insipidus and nephrogenic diabetes ADH. That means because in central DI we have said that ADH is decreased, but in nephrogenic DI ADH resistance is there, so ADH is normal or increased due to feedback mechanism. And just remember the treatment: water restriction, desmopressin, hydrochlorothiazide, low solid diet, amiloride. That's it. And this is important: Sheehan syndrome. That is when there is severe postpartum hemorrhage. Sometimes there will be excessive loss of blood in the patient in a delivery case. In such condition, there will be ischemic infarct, and then it will be decrease in pituitary growth. The patient will be susceptible to hypoperfusion, and that means the pituitary gland will be necrosized, and so it will not release prolactin, no lactation, no menstruation, cold endurance, because no thyroid hormones. So these features combinedly known as Sehan syndrome, and this is important. Rest of it, you can try, you can read yourself if you want. And treatment is obviously hormone replacement therapy. Whatever hormone is deficiency, will go with replacement. And acromegaly is excess growth hormone. Adenoma, if it is in children, linear blood. I had said earlier also, because due to absence of epiphyseal fusion, they length and become very giant, gigantism. But in adult, there will be large tongue with the frontal bossing. We can see that frontal is coming outside. The facial features are getting very coarse, hard. Okay, deep voice, excessive sweating, impaired glucose tolerance, hypertension, LVS, diabetes. So I had said that what is the question was the last sign to appear in acromegaly in 2080, and there was like scotoma, central scotoma, peripheral vision. There were different options, and as you can see, there is no answer here also, and I am also not sure about the answer. And diagnosis is increase. This you can see, and there will be mass in MRI. And we have no option then resection of pituitary adenoma and give octreotide, and whatever hormones are getting increased, we have the drugs that antagonize it. So this is it. We have completed pathology of endocrine also. I hope I could simplify it. I know there have been a lot of things missing, and you will need to um, memorize it, learn it, and mostly do it along with the questions. So today you will go to any app, go to the endocrinology part, and just solve the question and come back again and try to find the answers more and more. Then you will be more clear. And if you feel any confusion, we have a Telegram group. We can discuss it over here, over there. Tomorrow, as I might be traveling, I might not be able to uh, continue the class, but we'll complete endocrinology with very short pharmacology part. Diabetes mellitus, we need a bit explanation. And other is if hormone is less, we'll replace the hormone. If hormone is more, we'll try to give the antagonist. That's all in the endocrinology, very easy. So till then, stay happy, stay healthy. Have a good night.